For joining us. This is Sarah Horst from ICSI. We are watching people come into our waiting room, and so we're just going to give everybody another minute or two as they transition from other meetings into this one. Glad you're here. Please introduce yourself in the chat. Also, feel free to rename yourself, putting your organization after your name in your box.
Sarah, Stefan should be able to share the slides as a presenter.
Okay.
You'll just need to make sure to unshare your slides.
Perfect. Great. Welcome, everyone. We'll get started in just a moment. Please introduce yourself in the chat. Rename yourself, include your organization so that as people take a look at our participant list, they're able to know who you are, where you're from. Glad you're here today. All right, let's get started. Welcome, everyone. This is Sarah Horst from ICSI. I'm really glad you're here. Welcome to the Zero Suicide Learning Collaborative. And we don't take for granted what it takes to actually be here. We are in, there's really not adjectives that describe the times we're in: extraordinary, unprecedented, uncertain, as we deal with COVID-19. We deal with racial equity, systemic racism, as we watch our country transition power. These are very stressful times, personally and professionally. And so thank you for taking the time. I think this is a topic worth taking time for, as mental health and preventing suicide has maybe never felt so very important. So glad you're here and hope that the session adds value to the conversation today. Just want to introduce the ICSI team. I am the project manager, program manager for this. I'm joined by Senka Hatsik, our facilitator. She is also the one who is doing our tech and managing our breakout rooms. So thanks, Senka. And of course, you all know Patty Stack, the glue that holds us together and our most trusted partner. Joining us also is, this is a partnership of the Minnesota Department of Health and ICSI to bring this program to you. And we've got Tanya Carter, our supervisor of suicide prevention, and then Jenny Thielander, the suicide prevention health systems coordinator. We are your backup team and certainly available to help as you need. A reminder also that within this partnership, we do have these monthly learning collaborative meetings where it's 2 hours to come together once a month. The first hour will be some sort of teaching, training, networking, and the second hour we reserve for team time. We've heard loud and clear that you really value that time to get together and do that work. In addition, you have MDH trainings available to you free of charge. These can be done at your location via Zoom, and you can customize to your needs. And I've got the trainings listed here. And so please do, if those are things that are interesting to you, or if you feel that your team needs a boost, let us know and I can get you connected to the MDH resources. I think that's really one of there's a lot of advantages to being part of this learning collaborative, but I think these free trainings are really pretty great. And then just want to do a teaser for our upcoming topics. So today we're going to be hearing from MDH and talking about data. Next month, we'll be talking about gun violence. And we've invited Dr. Tom Kodke, the medical director for well-being from Health Partners. He's also a senior clinical investigator for Health Partners Institute. He is certainly a good friend to ICSI, very knowledgeable, and he'll help lead the conversation about how to work with our patients on guns in the home. as it pertains to suicide prevention. And then on March 16th, we're really excited. We've invited Becky Stoll, who's from the Vice President for Crisis and Disaster Management at Centerstone. Centerstone is a nonprofit health system providing mental health and substance use disorder treatments. They are based out of Tennessee, but they offer their services nationally, and they have done a tremendous amount of work successfully implementing zero suicide within their system. And so we've invited Becky to come and just talk through lessons learned, what worked, what didn't, and what advice she would have for our health systems as they are on their journey. So we're really excited about these upcoming topics. Again, those are during the first hour, second hour reserved for the team table time. So for today, our objectives, we always have a no, feel, do. And I want to preface this with, we know you are, there's a lot going on. And so we want to continue the Zero Suicide Learning Collaborative, but we also want it to be a low lift for you. We don't want to overburden you with compliance issues, with reporting. And so we want to, again, we challenge ourselves to what can add value, but not be too much. What's the right dose right now? And so today, our no is we want to listen and learn about the latest suicide data from the Minnesota Department of Health. We want you to feel connected to other organizations doing the same work. So as you scan the participant list, as you see who's there, think about who you may want to network with, who may have answers for questions you have, or who may need the solutions you have. And then do, we know that you're all working to execute action plans. And so we just ask that you continue the good work you're doing on your 30, 60, 90-day plans. And then as you continue to identify gaps and needed resources for implementation, let us know. Our agenda for today is we will have our speaker till 11 o'clock. Or till 10:45, we'll have an opportunity for some Q&A from 10:45 to 11. We'll move to team table time, and then we'll bring the group back just for housekeeping questions and next steps. This prompts me to remember to remind you of the antitrust statement that is in your packet. Of course, we come together as collaborative partners, but we acknowledge that our organizations are in a highly competitive healthcare environment. If at any time you feel that the conversation moves to an area that might violate antitrust, please speak up immediately and we will course correct and stay out of that territory. And so with that, I'd like to introduce our speaker for today, and we're really excited. The topic is racial and gender disparities for suicide for 2019. And I just, Stefan and I haven't spoken. I'm going to ask him to pull up his slide deck. I will introduce him and then I'll stop sharing. But our speaker today is Stefan Gingerich. And he joined the Minnesota Department of Health in September 2020 as a senior epidemiologist with the Injury and Violence Prevention Section. And he's a coordinator for the National Violent Death Reporting System. In this role, he works with a large team to collect and analyze data to help prevent violence and injury throughout Minnesota. Prior to MDH, he served as a senior research analyst at Staywell, focusing on developing surveys and normative statistics, applying scientific research to improve the health of workers across the nation. I love to know that our epidemiologist is also highly creative, and he studied choral music as his undergrad and as part of the Minnesota Chorale. You can see the rest of his wonderful education here. He is a Master of Science and Epidemiologist from the University of Iowa College of Public Health. And he's worked as a microbiologist for the state of Iowa. As well. So you can read the rest of his bio here. But Stefan, we're really excited that you're here and eager to hear about the data. I'm going to go ahead and stop sharing, and please let me know if you are able to share your screen. Perfect.
Should be on its way. You guys can hopefully see my slides.
Yes, we can.
I'm going to enter presenter mode, so it's that much easier for everybody to see. So first, I just want to thank everybody for being here today, and I want to thank everybody for the opportunity to talk about the 2019 update. This is the epidemiology of suicide for Minnesota in 2019. And so when we talk about epidemiology, lately it's been all about short-term acute epidemics occurring, outbreaks, pandemics, all these words. And unfortunately, suicide is similar in the sense that the definition of an epidemic is usually that we're seeing more cases of a disease or a condition than we'd expect or we'd want to see in a population. And suicide is certainly that way for the state of Minnesota. Just a quick background or sort of disclaimer for some of these slides, however. None of this is from an official published report or peer reviewed. I created these slides specifically for this meeting. And so as such, they should be considered relatively preliminary. I'm confident in the trends and the general sort of vicinity of the numbers that you'll see today. But if you'll see in the future that some things changed by 1/10 of a percentage point or a certain number of cases per 100,000, that is, could potentially happen. The numbers are subject to change, but again, like I said, generally speaking, I'm confident in where these numbers are sitting right now, which is unfortunately a new annual high for the state of Minnesota in 2019 for the number of suicides across the state. There were 830 suicides across all of Minnesota in 2019, which is the highest number that we've seen on record. Certainly the highest number that we've seen in the past 20 years. As you can see from this chart here, we've had this sort of a continuous, consistent trend over the past 20 years of increasing suicides across the state. Now, it's certainly true that a portion of this can be attributed to population growth. So there are more people, you would expect, more cases of any condition really. And so to adjust for that, what we do is we calculate the suicide rate. So this basically adjusts for population size. So as the size of the Minnesota population grows, we can adjust that so that we're making a better apples to apples comparison. It also allows us to make an apples to apples comparison of the United States and Minnesota to see how we're doing compared to the rest of the nation. And again, the news here is not good. You can see back in 1999, the Minnesota rate for suicide was 9 cases or 9 suicides per 100,000 people in the population, whereas the United States was 10.5, 10.5. Over the past 20 years, in Minnesota, that gap has closed so that we're actually a little bit higher than the rest of the country. Minnesota's 14.4 suicides per 100,000 people in the population, and the United States is closer to 14. So again, just sort of recognizing that there is a long-term epidemic of suicides. In terms of what we would expect, I think we'd hope at least for 0 suicides, which is obviously part of the goal of this group and this initiative. But in terms of the trend, we'd at least hope to see a flat line, if not a descending line, which is not what we're seeing over the past 20 years in Minnesota. For many of you, this may not be news. It's just sort of a continuation of what we've been seeing, like I said, for the past 20 years. There was a little bit of a signal in 2018 that maybe it was headed back in the right direction. 2019 has sort of gone the opposite direction from where we'd hoped. And in 2020, I'll get to that towards the end of the presentation, but the news there is better. It's not great. It's looking a little bit more like 2018. Those numbers are still preliminary though. So we talked, or I should say the title of the presentation, the subject for today is disparities. And when I say disparities, I just mean that suicides do not affect all populations equally. There are some populations in which there are more suicides than others, comparatively speaking. And one of those disparities is in gender, where we see males are more likely to die by suicide. They have higher rates of suicide, and they've had higher rates of suicide, at least, like I said, again, for the past 20 years. Talking to some of my colleagues who have been at the department longer than I have, this pattern has been very similar for as long as we've been collecting and analyzing data on suicides and gender. So that typically, when we look at the numbers, it's males have 3 to 5 times higher the rate of suicide than females. This past year, 2019, for the year we have most recent data, the rate for males was 22 per 100,000 individuals, and for females was 6.7. Although it's noteworthy that most of the increase that happened from 2018 to 2019 is attributable to an increase in females. So if you see down here in the bottom left, That rate in 2018 for females was 4.8. It increased by almost 2 points per 100,000 people, or two suicides per 100,000 people for females. And so that increase accounts for most of the difference between 2018 and 19, which is a trend that we'll certainly be watching. We hope to bring down in the coming years. In contrast to that, when we talk about death by suicide, there are also obviously suicide attempts, and those are more common in females than in males. So this is data from 2017. I'm in the process of working on this data for 2019 and 2018, and to see if this trend continues. But in 2017, the year we most recently have data, females made up 66% of hospital-treated self-inflicted injuries. And so this is an instance where someone presents at a hospital with an injury that they have inflicted upon themselves. Often it's poisoning, sometimes it's suffocation or cutting or stabbing, something of that nature. And as you can see, that is disproportionately females presenting at hospitals as opposed to males. A portion of this discrepancy or disparity is due to the mechanisms, which we'll talk about in a few slides. Males tend to use firearms more often when attempting suicide, and due to the lethality of firearms compared to other forms of self-inflicted injury, that's what we attribute some of the difference in suicide rates for males and females. And so there's this sort of decision that we all have to make, or that we make in suicide prevention of, do you focus on males because they make up the majority of the death by suicide, or do you focus on females because they make up the majority of the suicide attempts, or do you sort of spread it out as evenly as possible and try different interventions for different groups of people? And I think Tanya can tell us more about that. That's her area. I'm just the numbers guy. In terms of disparities among racial groups, there are also differences between racial groups, similar to what we saw in the gender, the sex groups in the previous slides. So for most of our racial groups, we divide those into 4 categories. I realize there are other racial groups. Fortunately, the numbers are low enough among suicides in those racial groups that we have to combine those into these 4 categories to capture statistics. And so again, what you see here is sort of a discrepancy between who makes up the majority of the numbers of suicides and who makes up, or who's more affected in terms of their population rates. So white people make up the vast majority of the suicides in Minnesota, at least in 2019. And this is consistent, again, going back 5, 10, 15 years. There are variations, but the patterns generally tend to hold. White people, because they make up 85% or so of the Minnesota population, they make up 721 of the 830 total suicides in Minnesota in 2019. You can see that is far outpacing any other racial group in terms of sheer numbers. However, when you adjust for the population size, you notice that the American Indian groups are suffering far more numbers of suicides per person or per 100,000 people than any of the other groups. That's 2 to 3 times higher, in some cases 4 times higher than other racial groups. So 37 out of 100,000 individuals in the American Indian population compared to 14, 11, and 10 for the other racial groups respectively. And so again, it sort of prevents this decision point where, do you focus on white individuals who make up the majority of the numbers, or do you focus on the American Indians who are disproportionately affected in terms of the number of people that are in the population? Or do you sort of try to do both at the same time and have these broad-ranging, broad-based strategies? Looking a layer deeper, when we combine age with race, we notice that the age distributions of suicides by racial groups are quite different. Again, with the white individuals, we know that they make up the vast majority of the numbers of suicides, and the majority of those occur in that age band between about 35 and 65, with the most prevalence, the highest prevalence, 45 to 54 years of age. Again, the majority of those are males, and so you see start to get a picture of who these individuals are sort of on average. But when you look at other racial groups, you notice that pattern is very different, where we've got this higher peak in the 15 to 24 age group and the 25 to 34 age group. And so you're looking at a much younger population of individuals in the minority populations compared to the white populations in terms of who is dying by suicide over the course of the past 20 years. And when we take a step sort of upstream from that and look at suicide ideation and attempts, this is specifically among students. And so this is an age group of 8, 9, and 11th graders who were offered the Minnesota Student Survey, asking them, in the past year, have you thought about or attempted suicide, seriously thought about or attempted suicide? And again, you can see the rates differ by age or by racial group, where the American Indians are most likely to report suicide ideation and attempt across any other, compared to any other racial group. And those other racial groups are a little bit lower, but still obviously higher than we'd like to see. And so again, this just sort of drives home that those teens in the American Indian populations are probably an area that prevention efforts would need to focus because they're disproportionately affected. There's a disparity there. And so I mentioned the mechanism of suicide and how that plays into or affects a little bit the gender disparities. The three primary mechanisms of suicide that we find when we look at the data are firearms, suffocation, and poisoning. Other mechanisms of suicide, such as jumping from high places or jumping out into traffic or in front of a moving vehicle or something like that, those make up a significant portion of the suicides, but each of those individual types, those mechanisms of suicide makes up a smaller portion. And so you can see across both gender groups, there's somewhere in the ballpark of 40 to 50% of suicides are attributable to firearms, but that differs greatly when you compare males to females. And so males, as we said, make up in the ballpark of 75% of the suicides in Minnesota. Of those suicides among males, half of them are due to firearms. And so that, like I said, plays into the discrepancy or the disparity we see in suicide attempts, where females are more likely to present at the hospitals for a suicide attempt or a self-inflicted injury, in part because when they attempt suicide, they're using different mechanisms, such as suffocation and poisoning. In fact, those two groups, or those two mechanisms of suicide in the females make up close to 80% of all suicides in Minnesota. And so again, you see, in terms of interventions and prevention strategies, there probably needs to be a difference between those strategies for males versus those strategies for females in terms of access, or I should say, limiting access to lethal means. Similar, I should say, somewhat different patterns in terms of suicide attempts, which we touched on a moment ago. This again is from 2017 and looks at the number of cases of self-inflicted injury at hospitals in Minnesota by mechanism of those self-inflicted injuries. So in essence, how were those self-inflicted injuries occurring? A smaller percentage of those were from cutting and piercing. The largest percentages from poisoning. And again, that other category, that includes firearms. And so you see there aren't a great deal of injuries presented at the hospital due to firearms. That includes other mechanisms as well. And so again, when you look at the difference between the patterns in terms of the distribution of mechanisms of suicide attempts versus death by suicide, you see there is that discrepancy there that needs to be considered when designing prevention programs. And so that ends the 2019 portion of the presentation. I'll talk a little bit about 2020 data, and I think we'll have plenty of time for some questions. In terms of the overall number of suicides we have counted so far, this data comes from death certificates, and death certificates do have a little bit of a delay in terms of, from the time that the death occurs to the time that the data is complete and therefore sort of trustworthy to analyze and present. And so this summarizes the suicide count through October of 2020. And when I compare it to previous years, this again goes from January to October of previous years. And so you can see from January to October of 2018, there were 626 suicides in Minnesota. 2019, again, that increase from 2018, so there were 696 suicides from January to October in 2019. And then in 2020, it's similar to 2018. As I mentioned, still higher, obviously, than we'd like to see, but it doesn't appear that 2020 is going to continue that increased trend that we saw from 2018 to 19. And I think it's, in some sense, good to see that it isn't higher than it was, because 2020 was such a unique, stressful, mentally sort of stressful year. And so I think there was a lot of concern throughout 2020 that there was going to be a very large increase in suicides. We have seen an increase in overdoses. And so this gets into a little bit of a discussion about when someone overdoses, it's deemed either accidental or intentional. Oftentimes it's difficult to identify that overdose as intentional unless there's clear evidence that it was intentional and therefore a suicide. And so a portion of the increase that we've seen in overdoses in general may have been suicides that were not counted as suicides. So the 2020 number may be a little bit of an undercount in terms of the number of suicides. That's similar to previous years. It may be a little bit more of an undercount in 2020. So, when you combine suicides and other unintentional overdoses, that gives you sort of that a general sense of so these similar preventable deaths that are occurring due to substance abuse. And again, just looking quickly at the sort of gender disparity that we talked about before, for 2020, the data is consistent with historical trends. It's not consistent with what we've seen historically for suicide attempts again. So we've got this majority, the large majority, 79% of the suicides in 2020 so far that we've counted have been for males. And I have every expectation that the suicide attempts will sort of see this gender disparity flipped again, where we see the majority of suicide attempts among females compared to males. And again, somewhat consequential of the use of firearms among males. So that concludes the slides that I had planned to present today. I'll be happy to answer whatever questions I can. If there aren't questions, or if there are questions I can't answer because I've only been doing this since September, I'm happy to punt those over to Tanya or Jenna Lee, or take down your contact information and get an answer back to you as soon as I can.
Stefan, I just want to start off by saying thank you very much for putting together all this information.
Thank you for letting me present it.
I am curious about the jump from 2018 to 2019. Has there been anything that's been identified to contribute to that?
At this point, I don't know of any specific contributors or causes that we'd be comfortable identifying. I know that generally speaking, we saw that trend that's been going on for 20 years. And so it's possible that 2019 was sort of a unique spike. It's also possible that 2018 was a unique dip, and that something happened in 2019 to bring down the suicide rate that was absent in 2019, if that makes sense. If you look at the overall trend, I think, had we projected in 2017 what 2018, 19, and 20 would be based on that trend, I think 2019 was actually fitting the trend. So as much as I don't want to say we kind of expected it, we certainly didn't want that to happen, but it's an increase that we're looking into. We don't know that there's necessarily a specific cause. I'd invite anybody else to add to that as well, because whatever ideas we have, we can certainly consider looking into what those might be.
Stefan, this is Jeff Leichter from Sanford Health. Thank you for your presentation. Our health system is largely across a huge rural path that includes Minnesota. We are not in the Twin Cities or any of the larger urban communities. Do you have any comment about the rate of suicide attempt or completed suicides based on the rurality, if I'm pronouncing that word right, versus urban density? We make a lot of hypotheses that the availability of mental health services is a factor in completed suicides. And as we get farther out of the Twin Cities, for example, do you see any trends as we get more into small communities and more frontier communities?
So I've seen some rates comparing the urban versus sort of suburban and rural and different areas. I cannot remember off the top of my head how those rates compare. I know in terms of the number, it's fairly evenly split. So yeah, I'm not sure I can answer that. I'll take a look at the 19 data and send out sort of some numbers to this group to answer that question, because I think it's an important one, like you said, for people who don't have access to mental health services or maybe have to drive further for any sort of health services. I know oftentimes chronic pain is a contributor to mental health issues and subsequent suicide attempts. And so obviously access to any type of health service at all is probably going to have a role to play in that. But again, I'd invite anybody who's seen recent statistics on that to chime in, because I haven't looked at them recently enough to know off the top of my head.
So this is Quanah Walker from Health Partners, and looking at this data today, and then also I was thinking about a presentation I heard last week, and you have someone at the Minnesota Department of Health, Luther Talks, and he's actually his whole position is focused on suicide prevention for American Indians. And I'm just wondering if it wouldn't be a worthwhile thing for the ICSI team and then the MDH colleagues on this initiative to think about having him come and present. He has some of the data aligns with some of the slides that you had, but I think it might be helpful when you think about how disproportionately American Indians are impacted by this and the rates. And I think I've thought about this before, but it's a good time for me to just say it. Some of the healthcare systems that are in this Zero Suicide Initiative, like Sanford, you were just saying, in North and South Dakota, and then in Minnesota, there's a large number of Native nations in their service areas, and there's larger percentages of the population that are Native. It's still small, but I really would encourage the health systems where there's that opportunity to think about what they could do, what initiatives they could do to support American Indians, because you do have them as patients of your hospitals, clinics, etc. So I wanted to put that out there. And I think, again, it might be really helpful to have somebody like Luther Talks, who's an expert, and he's the MDH person that works with that population, to share some things with this group.
I absolutely agree. I think one of the reasons that this data might seem similar is because I've shared this with Luther. Luther and I have worked together. In fact, he is on the same team as Tanya and Jenny Lee, who Sarah mentioned earlier on the call. I don't know if Tanya's here or not, but she could certainly speak to Luther's availability and his skills. We have presented this data to the tribal health leaders recently, so they're well aware of the issue. And I would even add that within the Twin Cities, I think I was talking to one of my colleagues yesterday, and he said that half of the Native population is in the metro area. So it's a substantial portion of our population too. And so even if you're in the Twin Cities, they're your patients, especially depending on your neighborhood or your geographic location.
Juana, this is Sarah from ICSI. I really appreciate that call out. We've got it written down and we will bring it forward. You asked, we'll deliver.
This is Lisa Burshak from CentraCare. I was wanting to ask a couple questions about kind of the mechanisms, because I think from a clinical standpoint, some of that data can help inform how clinicians in our respective healthcare organizations think through safety planning. So I know I've been sent some data before, and so I pulled for the CentraCare catchment area, which is like 18 counties. I looked at kind of means, how people were attempting or completing suicide. And one of the things I'm wondering is, have you looked at mechanisms and broken it down in age ranges for the newer data? Because one of the things I had found when I looked at children and adolescents 18 and younger in our catchment area over those 3 years, 16 through 18, it was a 50-50 even split between children and adolescents who died by firearm and those who were dying by hanging, which is, you know, a little different than kind of the groups that we see for mechanisms with older individuals. And then I'd also looked at a trend that over those years, suffocation, which is typically hanging, but can include other mechanisms like, you know, bags overhead and things of that nature. I was seeing a trend where people were dying more often by hanging, right? Because it's also highly lethal, like a firearm, you know, 3 to 4 minutes. And I'd put out to the Zero Suicide listserv just seeing, you know, how are people thinking about risk mitigation for hanging in safety plans? It's not the same conversation. There's so many things you can die of in your home environment from a hanging perspective. And everyone who had responded, I had a number of responses, said, yes, in our states or in our areas, we're seeing trends go up with hanging deaths. But everyone said the same thing. We're perplexed at how to help have these safety plan conversations around risk mitigation for hanging. And when I'd shown some of that data to some of the clinicians here at CentraCare, we had some conversations about it. You know, they said, well, hey, it really helped inform my practice. We're not quite there yet. You know, it's not the same conversation as can we remove a firearm temporarily? But there was a conversation of just having that data from a clinician standpoint helped me think through that these are some questions I should be asking more specifically about in terms of people's thoughts with a plan. So I'm just wondering if there you have any plans to kind of break down the means with age groups and if we can try to get a clear sense of mechanism, because I think there's actual work there we can do from a state perspective in terms of safety plan training for clinicians and looking at other, you know, campaigns related to mechanism. So just wondering, you know, if you have any plans to break that down further.
Yeah, it's certainly something that I can look at. I've looked at it relatively recently. I think what you're saying is consistent with what I saw. It does tend to be more of the older males who have presumably easier access to firearms and then die by firearms as well. So like you said, sort of the younger groups, there's a difference where it skews a little bit more towards suffocation and poisoning for sure.
Stefan, this is Sarah from ICSI, and I appreciate, you know, ICSI does a lot of work, as does everyone on the call, on the area of opioids, and where we can control is opioid prescribing. And so that's something we look at. And you talked about how it is really muddy to understand overdose. Was it intentional or was it not? And I think, we know it's muddy. We acknowledge that. We know we're looking at death certificate data. Is there work to help us discern in that opioid lane, how to kind of tease that out? I had seen some MDH data previously, and it was kind of the deaths of despair, and it had suicide, then it had firearms, then it had opioids. I thought it was so strange. The suicide is an outcome. You don't die by suicide, you die by a mean, and the outcome is suicide. And then it was breaking out the other things. Is there, can you speak to any effort to really make that data meaningful from an opioid standpoint, and then also to just do more, like to Lisa's point and everyone's point, to just get at the means so we can understand what strategies to put toward it.
Yep, there is work happening. I don't know that it's not going to be a fast sort of quick solve that we have for that problem. I think generally the thinking that we tend to have on it is that the idea of intentional and unintentional is somewhat of a false dichotomy, in the sense that it really occurs on this continuum where, you know, you have these truly unintentional overdoses where a person is looking to get high or have fun with their friends, whatever their intention is. It's not to end their life. And then on the other extreme, you do have instances where that's the absolute intent of the person. They leave a suicide note or something else that makes it clear that that was their intent. And then you have this continuum in between where maybe they're depressed and somewhat apathetic about whether or not they live or die. Maybe they were just trying to numb the pain for whatever their cause of pain is, and they were trying to take a little bit more than they typically do, or trying to you know, take 2 pills instead of whatever the case may be. And so we do have some data that we think can help us identify steps along that continuum of intentionality. We don't have a real methodology built around it yet, or any sort of certainly not anything that's been validated in terms of identifying, you know, more or less likely to be intentional about overdosing. But it's something that we recognize as a gap in the data, and we're absolutely looking to try and fill it. The downside, I think, is that a lot of times those data collection efforts are time consuming and costly and resource intensive. There's a methodology called a psychological autopsy that requires training and real in-depth analysis of the circumstances around an individual death by multiple people who have expertise in different areas. And that's one way of identifying, you know, whether there were some signs that lead up and sort of indicators that this may have been intentional. But again, it's time consuming and costly. So it's not something that we've been able to do a lot. So that's kind of where we are on that. We certainly recognize that it's an issue, and we're hoping that we have better information in the future to address it.
This is Chad Brown from Sanford and West Fargo. Going to this opioid part, I was just curious about the frequency of doing screening for suicide or suicide assessment for patients that do present for an opioid overdose. I'm wondering about mandating that all people that present have that type of an assessment completed, if that would be valid or something to maybe look into doing. Because I think that lots of times when a patient presents, they don't always, it's a lot of it, I think, is a bit dependent upon patient report. But I just wonder if we utilize patient report along with screening and along with an additional assessment, if we could get into that mindset of this being a mandatory process for all of those, I would wonder what kind of data we would find.
Thanks, Chad. Is anyone doing something like that, or have a package for their follow-up post-overdose? Is anybody doing anything like Chad's suggesting? It's a good suggestion, Chad. So some things that have bubbled up from the questions here is an opportunity to bring Luther Toxin to speak more specifically to the American Indian population. Looking at diving in specifically to risk mitigation for hanging. And then also this idea of, from death by opioids, really getting into screening or some sort of standard package when they come in for a follow-up visit. What other questions? So first of all, Stefan, thank you for a fabulous presentation and just a lot of food for thought. What other questions do we have as a group What are the gaps in the data? What are ways that MDH could slice the data, present the data that would help add value to the work that you're doing? While you're thinking, Stefan, I know you said you were just, and so also thank you. You've just been doing this in September, so appreciate you sharing with us. You said you were working on 2020 data. What type of timeline can we expect to learn more about that?
I'd say it's going to be several months until I'm comfortable trusting the death certificate data. What we've seen so far, like I mentioned, it appears that 2020 is going to be similar in terms of the suicide count for 2018. I have every expectation that those patterns that we talked about are going to be similar again, where the majority of suicides are among males, among whites, and the suicide rate for American Indians is going to be the highest of all racial groups in the state. Anything that really changes from those patterns that we talked about with the 2019 data would be very surprising to me, because as far as I've gone back in the data the past 5 or 10 years, just looking at those same patterns, they've held. It's almost always majority 3 to 5 times higher for males. And like I said, the suicide rates among the American Indian population has typically been 2 or 3 times higher than the other racial groups. So those are pretty solid patterns that I think we can count on continuing in 2020 and 2021 and probably years on into the future.
Thank you.
So this is Quana from Health Partners again, and I'm just curious to hear from anyone on the call that's already doing work focused on specific groups or gender, if they can share any of that, or is anyone on the call like in the process of designing interventions that are very specific to certain groups? And then another, I guess, part of that question would be, so, I mentioned Luther Talks, and there could be an opportunity there. And that's, I'm sure, because of the issue being so apparent, and over time, that there's a different situation going on with that community. But, even from an MDH perspective, do they have other initiatives or other advocates focusing on specific groups?
Anna, this is Lisa Bershock with CentraCare. So we're having some early conversations with some of our Somali health workers, because we have a really large population in St. Cloud of Somali community members. And there's a lot of different kind of cultural stigmas around seeking mental health care, talking about suicide. So we're starting some of our conversations to determine how we can translate some of our resources into Somali language. We're having some conversations about, how do we maybe change the message a little bit to reach people where they are now, and think about kind of a message that changes over time. They've had some luck in just having general conversations around mental health. So that's kind of an area we're trying to focus on at the moment. And then I think the question I'd also have for this team is, we know we have some communities within our larger communities that are higher risk, yet some of the work of just zero suicide is a massive lift for our organizations. And so competing interests between trying to launch things that just make it safer for everyone universally, and then thinking about some of those selected populations and how people are prioritizing some of the work, I'd be really interested to hear feedback.
While people are thinking, I really appreciate Kwana and Lisa, you kind of bringing up your point of view. We also see Amy Nygaard from Health Partners in the chat saying, I'd love to have a focused discussion or presentation on harm reduction strategies and education or support for patients from groups who have been, from a group who's been successful in standardizing this. So I think more to come. And Lisa, I think I appreciate, and this is kind of the tension anytime we do work is, wow, we're really not nailing it 100% just in general, let alone honing in on a quote unquote disparity. It becomes really hard strategically from a resource perspective. I want to add a question, and what stood out to me is just really the need to have different interventions for male versus female. And as we think of equity and disparities, it's almost we go instantly to race and ethnicity, like that's the disparities work. And I wonder kind of how that fits for everyone to just have it be a gender disparity. That it's very binary, male, female, and that's not kind of the high impact or the we really want to get to that specific population, that American Indian, the Somali, those kind of things. So it's just, there's so much work, and where do you focus? And I see Kwana is also talking about transgender and LGBTQ. So as the data is showing, so the question, Stefan in the chat is, does MDH collect data at this type of a granular level for gender? But
so yeah, so on death certificates, that data is not available. We do, I think, as we mentioned in my bio, there's the National Violent Death Reporting System that does have some of that information. And I think we've fielded a few questions, or at least Tanya mentioned to me a few questions she's received specific to youth, transgender, LGBTQ populations. And I think, in terms of sort of data collection challenges, one item is probably that, with suicide, we don't have the opportunity to ask the decedent what their gender preferences are, what their gender identity is. And so you're depending upon family members or friends for that information, or maybe there's something in their medical record or the law enforcement report or something. That ultimately, we're depending on other people to tell us this information. And so my hunch is that there's going to be quite a significant undercounting, again, of individuals in that population when we have that data available. That said, it's certainly something that we're aware of and we're looking into, and we'll hopefully be able to have some numbers available. But when we look at those numbers, we're going to have to sort of mentally adjust for the idea that there are probably several people who identify as some other gender than what their family was comfortable telling law enforcement or the medical examiner, or just in general, there's going to be some holes in that data that's going to be challenging.
Yeah, and I can share too. I totally agree with Stefan. From our perspective, I mean, we have the Minnesota Student Survey. That is administered.
Jenna Lee, you're fading in and out. We're not able to hear you.
I'll put it in the chat.
Thank you. Sorry about that. Jenna Lee's internet is going in and out. So she is our MDH rep. I'm watching the clock. We've got a great comment from Jessica Malone in the chat. At Hennepin, we haven't targeted any aspects of our work at specific populations, but we're starting to weave equity into our work by exploring how we can leverage our interpreter services to provide the CSSRS linguistically validated versions, and how to get patients' words in their language into safety plans. We haven't explored gender at all yet at Hennepin yet. One of our goals at ICSE, as we do this complex work, this is complex adaptive systems change, is to create the space for things to emerge. And I think that's exactly what's happening today. And we also agree that things don't get wrapped up with a bow neatly. And certainly for this topic of preventing suicide, there's no, if there were an easy answer, we'd all be doing it. And so I really appreciate and value Stefan's data and then the really thoughtful questions and also the cultural humility as we come together and we admit what we don't know, we admit what we're curious about, and we put the questions out there. And so we are taking notes at ICSE. This helps inform our future topics. As if you're listening and you have solutions, please send them forward. We do want to act as a hub and a knowledge network, and we'll distribute those things. But in our last 3 minutes before we move to our team table time, what else might we want to add to today's conversation?
This is Chad Brown. Last semester, I taught a class, suicide prevention class at UND. And one of the assignments that I had for the class members was to understand more about services that were available in the community. And I had them focus on specific populations. And what the class brought back from that was that it wasn't that there were services, it wasn't that there was not services available for each of these populations. What I think it came down to was that the services within the service is where the limitations could be. So there might be a service for the LGBT community, but they might not include within that about suicide prevention. And so I just wanted to share that in saying is that I think there's a lot of resources that are available to the different populations. I think it comes down to a matter of are all these services also including within their work suicide prevention intervention?
Thank you, Chad. That's eye-opening, where so often we have a great referral to something that's really culturally specific, culturally appropriate. And yet you're absolutely right. If they don't have the tools, training, and resources on this topic, it's for naught. Is anybody addressing that, or is anybody working with community organizations? And maybe this is for Jenna Lee at the state. Is there a push to get community organizations educated on zero suicide or what to do? And generally, I'd included in the chat when her audio cut out that the Minnesota Department of Agriculture is doing a lot of work specific to mental health and suicide prevention for rural farmers. So, other thoughts? Thank you, Chad. Well,
So if I can just add one more thing sort of as a farewell, I think in general throughout the past year, public health and epidemiologists have realized that part of their job description is delivering bad news. And I think in terms of where we go from here and what we sort of think about as realistic expectations, a lot of my former work had to do with weight loss. And we had sort of a saying that it took you 10 years to put the weight on. It's not going to come off in 10 days. And so you kind of have to realize there's going to be this arc similar to suicide. We've seen this 20-year consistent increase. And so I think it's probably helpful for all of our mental health to recognize that that's not going to come down in 20 days. It's not going to come down in 20 months. It may take years and decades of hard work to get that to come back down to where we were 20 years ago and beyond. And so I think as you think about the work that you're doing and thinking that it's doing no good, keep that in mind, that it's going to be a long, sort of play the long game as opposed to quick expectations.
thank you, Stefan. And I don't know how to do applause on Zoom, but let's do spirit fingers. Thank you so much for a really thoughtful presentation. This is very, it was great. All right. If there are no more questions, we will go ahead and do our breakouts, and Senka will captain this ship in getting you into breakout rooms. If there is anything you need, there's a question for host button or something in there. If you come out, it gets hard for you to get back in. So we'll go ahead and do that now, and we'll bring you back to the room at 11:55, just in case there are any ahas or sharing. But otherwise, enjoy your team time and really appreciate you being here today. So Senka is going to go ahead now and open the rooms. Where did my presentation go? Welcome back. It takes about a full 60 seconds to have all participants rejoin. So we'll just go ahead and let that clock run out, and appreciate your patience. And Senka, can you let me know when the rooms are completely closed?
So the rooms are closed completely right now, but not
Okay.
everybody's back yet. So I'm not sure,
That's okay.
but they're closed.
Okay. Well, everyone, welcome back. Thank you for a great session today, for your thoughtful questions, and I hope that you had really good and effective team time. And so in our final minutes, just wanted to know if there are any remaining questions or any breakthrough or ahas that you'd like to share with the group, and just want to open up real quick for questions or comments before we dismiss the meeting. Hearing none, just want to do a teaser for our upcoming sessions in February and March. And we really are trying to find that balance between being able to forecast our programming so you know what's to come, and yet being really responsive. And so we did invite Dr. Tom Kotke to our February 16th session to have a conversation about gun violence, lethal means. And we also had some really important requests today to dig a little deeper on specific interventions for targeted populations. So that inviting Luther Talks to talk about the Native American community from MDH. We also talked about standard follow-up post-overdose, risk mitigation for hanging. So we may put some of those topics on February 16th as well. As soon as we know, we'll forecast that to you. But again, want to let you know what's coming, and then also make sure we're really being responsive. And then on March 16th, really looking forward to Becky Stoll from Centerstone, and lessons from implementation. So thank you so much for being here today. Let me and Patty know if there's anything you need from us. Otherwise, thank you for the wonderful work you do to make a difference in the lives of patients, especially in very challenging times. I'll stay on the line for a minute if you have any questions. Otherwise, thanks for a really great session today. Appreciate your time.